Oh, good morning, and want to welcome you to Brookings. I'm delighted that you're here. And the start of today's topic really goes back to the hospital productivity trend assumption in the Affordable Care Act. And there were some predictions when that came out that this would be doom for the hospital system. Hospitals will go bankrupt. Two things appear to have happened to date. One is that hospital Medicare margins have dropped, but the other is that hospitals' overall margins have not. And an upshot has been growing divergence between Medicare rates and commercial rates, which likely is not a healthy development. So we need to analyze and better understand hospital productivity trends. If the productivity trends are coming in the form of higher quality of care, does that mean that we should pay higher rates, or should we tie more of our payments to value approaches so that quality improvements that are valuable actually get rewarded only when they're achieved? There's also the possibility that increasingly concentrated markets mean that Medicare rates have less of an impact on costs than earlier research had suggested. Has a degree of consolidation been reached that regulation of hospital rates needs to be considered? Anyway, we've got, it's just to tantalize things, we have a very compelling lineup of speakers for this conference. We're going to begin with a presentation by John Romley, a professor at University of Southern California in the Price School of Public Policy and a key affiliate of the Schaeffer Center for Health Policy and Economics. He's going to be synthesizing the literature on hospital trends, giving his interpretation, and we'll have two reactors to John's presentation. And also, John gets the prize for being the most jet-lagged person at this conference. He came in from Hawaii, so be easy on him. Two reactors, my colleague Louise Shiner, who's a Robert S. Kerr Senior Fellow in Economic Studies at Brookings and the Policy Director of the Hutchins Center on Fiscal and Monetary Policy. And the other reactor is my former colleague, Chapin White, who's currently an adjunct senior policy researcher at RANDS. Then we have a panel on the policy dimensions of hospital productivity trends. Louise Shiner will moderate, and it will include, in this order, Paul Spatelnik, the Chief Actuary at CMS, Jim Matthews, Executive Director of MedPAC, Chapin White doing double duty, and Stuart Altman, now Chairman of the Massachusetts Health Policy Commission and a professor at Brandeis, and many years ago, the Chairman of the Prospective Payment Assessment Commission, one of the predecessor commissions to MedPAC that annually wrestled with these issues. John.
So I'm fortunate that my work brings me to a tropical environment. Thank you for the invitation, Paul. So I'm going to talk about productivity, focusing mainly on hospitals, but also trying to think a little more broadly. This is a big topic, to be sure, and I'm not going to be able to do it full justice. So, you know, if you're one of the folks whose papers I don't discuss, I apologize, but I'll do my best. Okay, so as a society, we have finite resources to try to achieve the things we want to achieve, and so we could think of, you know, various combinations of health that we might achieve through devoting resources to healthcare. Keep it simple, healthcare, ignore health habits and other things. And what we don't use for that, we can use on other good stuff, right? We might devote 0% of our GDP towards health. We might devote, at that dot on the curve, all of it. And if we think just about healthcare, we're around here. Oops, there we are. Here, suppose we're at this point, and then somehow we get more productive at producing health. And then the combinations that are feasible look something more like this, and that's great. The sweet spot would be, well, here's higher quality. Oops, that didn't work. Good enough. That's lower cost. And then the dark line is sort of that sweet spot. Higher quality, lower cost. Several years ago, the Institute of Medicine revisited the question of geographic variation in healthcare, and do we want to do geographic adjustment for value and that kind of thing. And there, sort of the preface to that report, and Paul served on that panel, the preface to that report was, well, ultimately, we can't just cut willy-nilly. We need to figure out how to get more value out of the system. And so that dark line on that sort of possibilities frontier, that segment of it is sort of consistent with that view of the world. Okay, so there's a big debate about the future of productivity growth in the U.S. I'm not going to get into that. I'll just note that Hutchins is really contributing mightily to that debate. BLS has applied a rigorous, well-developed, careful approach to looking at productivity growth across sectors of the U.S. economy. So here is manufacturing. People tend to think of it as dynamic. Here is a Tesla plant, maybe representing that well. Positive, substantial productivity growth over about 20 years. Here we have services. It's a grab bag of things, but maybe the classic example is a symphony and orchestra. Here's the LA Phil. And here we don't see a bar, right, because we're right at 0%. And then BLS actually finds not just not positive, but even negative productivity growth for hospitals and residential facilities and nursing homes combined. So that's pretty striking. This is consistent with the notion that first comes out of Baumol and Bowen of a cost disease, right? So you have sectors where you don't see new technologies coming along that generate efficiencies. At the same time, you have to pay people to work in those sectors or they do something else. And so certain sectors will just see ballooning costs. And healthcare has certainly been one of those areas that's been discussed for this kind of issue, right? So, and then that cost disease view of the world has made its way into how people think about health policy in the U.S. So a number of years ago, in the 2014 Medicare Trustees Report, this issue was taken up. Thinking about the solvency of the Medicare program, what do we expect for long-term productivity growth in healthcare versus the rest of the economy? And you see a substantial difference in what was projected. Okay, so Paul alluded to this fact that the ACA ties the annual updates and reimbursement to productivity growth. The thing is, it's productivity growth in the broader economy. So the ACA almost says it's on you, hospitals, to figure out how to keep up with the rest of the economy. If that's not feasible, that may generate some concerns about the viability of healthcare providers. At one time, the CMS actuary projected that a non-trivial fraction of Part A institutional providers would develop negative margins under this policy going forward. Most recently, MedPAC recommended an increase in hospital payment rates above the statutory formula due to this kind of concern. And so, this debate has been percolating for a good while about what all this means. In terms of literature, I think a good place to start is there was a nice special issue in the 2000 Healthcare Finance Review on productivity measurement. Here's a study by Fisher looking at physicians, and it more or less follows the BLS approach. So you have these different kinds of goods. How do you compare healthcare to automobiles or physicians to hospitals? Well, you start with total output as measured by revenues, dollars. So that's something that's comparable. And to move from nominal dollars into real dollars, you divide by a price index. So this is nice. It's grounded in theory, assumptions of competitive markets, in many cases, constant returns to scale. And, Holton, who's one of the leading thinkers in this area, calls this top-down because it starts with aggregate macro data series about various economic sectors. So what we see here, Fisher found, was not necessarily always negative productivity growth among physicians, but lagging the broader economy, consistent with this concern. Here we have a couple of folks from the CMS Actuary's office looking at alternative approaches to measuring productivity growth in hospitals. similar sort of BLS type work, and found either no growth or negative growth, depending on exactly what you did. But the thing is that productivity growth is very hard to measure, particularly in healthcare, right? So Chad Syverson at Chicago has made a career by looking at productivity in the cement concrete sector, right? So maybe not the sexiest sector, but because he's a social scientist, can't do physical science experiments, he was very smart to focus on a simple sector where there was nothing else going on, right? We don't have that luxury. Right? There may be trends in unmeasured aspects of the quality of care, right? We ultimately don't care about the inputs, we care about the health that's produced, right? So maybe hospitals and others have been using more resources, but to achieve better outcomes, right? And they're not getting credit for the benefits, but they are getting blamed for the costs. Or maybe there are trends that have not been captured in terms of how severe patients are, right? So they show up at a hospital or another setting with, a health history and health habits, and that ultimately affects how things turn out. And really the existing evidence, in my view, I can elaborate on this if anyone wants, doesn't really deal with these issues. As great as the BLS approach is, healthcare is kind of different, and it doesn't deal with these issues as one might hope. That's how I guess I would put it. So anyhow, my colleagues Dana Goldman, Neeraj Sood, we took up this issue again in a study that came out in Health Affairs, looking at 2002 through 2011 elderly Americans in fee-for-service Medicare, and combining health insurance claims, administrative records, and regulatory filings. So the nice thing is about this is we can see, when people go to the hospital, what their long-term outcomes are, or outcomes after discharge are. We know where they live, so some sort of context about their socioeconomic determinants of health, that kind of thing. We look at a range of important conditions and have some risk adjustment that really within, right? So some of that earlier work, they might look at DRGs, big sort of relatively big buckets, but there's a lot of variability even within a diagnosis. So we are going to use we used open source risk adjustment. That's a very contentious issue, risk adjustment, how to do it. But I think most people would agree that you need to do something, and that's something that we do here. Okay, so the very first thing you might do is just look at cost per discharge. That's sort of the inverse of productivity, right? And here we see across the board for these three conditions, not rapidly increasing costs, but they're all upward sloping, right? So we go from about 18,000 to almost 19,000 for heart attack, for example. That's not suggestive of productivity growth. Next thing we do is regression analysis, because we want to figure out how different approaches might lead to different results. So this is what I would call sort of bottom up, because we start with, rather than macro data series, we start with patients and providers. Here in our regressions, the unit of analysis is a hospital year. And you don't necessarily have to assume returns to scale, because in a regression you can relax that. In this study we don't. We do assume returns to scale, but in our later work we haven't done that. Anyhow, when you do the naive approach, when you think of hospital output as just the number of stays for these various conditions, we see negative productivity growth across the board. And in fact, for heart failure, we nail that BLS number exactly. I mean, I wouldn't make too big a deal out of that, but it's kind of consistent. Okay, so the next thing we do is adjust in our regressions for patient severity. Again, I don't want to get in the weeds on that, but I'm happy to talk about it at some point. And things do change a little bit. So for both heart failure and particularly for pneumonia, the picture is more positive, still negative on net for heart failure, but less negative. So that suggests that the patients are showing up sicker, and the naive approach was not accounting for that. And then finally, we define the hospital output by the number of high-quality stays. What do we mean by that? Well, a patient had to survive 30 days beyond the admission, and that did not show up well, but avoid an unplanned readmission within 30 days of discharge. And obviously these are very policy relevant metrics for CMS and others. All right, so when we do that, we're now looking at the blue columns, the blue bars, and we see positive and even substantial productivity growth across the board. All right, so this study suggests that how you do it really does matter. Now, I should acknowledge that quality of healthcare, worrying about that, we're not geniuses who are the first people to think of that, right? So going back to a couple decades now, the Boston Commission was thinking about, does the CPI, which is used to determine COLA increases for Social Security payments, does that overstate the true rate of inflation in the cost of living? Cost of living meaning cost of achieving a particular standard of living. And a primary concern there was technological change and the quality changes that were associated with that. Healthcare is a part of that story, and so David Cutler and colleagues looked at the price of heart attack treatment and found that accounting for better outcomes, the price of treatment decreased. Okay, so this is what's called a cost of living price index. Without getting into the weeds, I'd say it's really closely related to productivity, but not exactly the same thing. Louise actually has a nice paper sort of talking about why, and I think she's right, why productivity in sort of the BLS sense of the word is really what you want to be thinking about when you're thinking about payment adequacy under the Medicare, for Medicare. Okay, so anyways, that was hospitals, right? And maybe what this cost disease will manifest itself when we look at nursing care, right? Very, very low tech, not changing a lot over time. Okay, so we do the same kind of thing, looking at patients who are hospitalized, then first sent for post-acute care to a skilled nursing facility and look at their outcomes. Now quality is going to be surviving 90 days beyond the discharge, avoiding an unplanned readmission, and discharge to the community, return to community by the end of the stay or the end of the episode. And so we kind of walk through the various specifications. You see something very similar, that by the end of it, for these post-acute care intensive conditions, joint replacement, stroke, hip fracture, that you see actually a substantial productivity growth when you account for the quality of the outcomes that are achieved. So I'll try to talk briefly about where we might go from here. Clearly, quality has to be part of the picture going forward. I would say that even if particular settings are doing well, we do worry that the healthcare sector has all kinds of problems with information and coordination and that kind of thing. And so, some of the reforms or experiments in the ACA are trying to improve on that margin, right? So let's do bundled payment. Let's pay for populations, that kind of thing. And so I think, we want to move in that direction beyond encounters towards episodes of care and population health. I think we want to look at new populations and context. So Medicare is important for sure, but to a degree, it's like looking under the lamppost for the keys. It would be nice to look at Medicaid. It would be nice to look at the commercially insured. Childbirth happens a lot in this country, and we have a serious maternal mortality problem. It would be interesting, I think, to look at that. Analytically, there's this issue of top-down versus bottom-up. I don't want to get in the weeds on that. It's not just limited to healthcare. It's for all of productivity measurement, that issue, but it does play a role here. There are challenges with respect to the multidimensionality of quality. What's the trade-off between quantity and quality? I can talk some more about that. Something that often comes up is, well, what's behind all this? And I agree, that's a $1 million question. And so we want to assess some of the potential drivers of productivity. Have some of these innovative payment and delivery models help things, right? Questions like that. I will say that scaling up beyond the early work that we've done, that is a very data and labor intensive project, and so it's I don't want to end on a downer, but it's a little frustrating. I've wanted to get to this for a long time, but there's just a lot of work to be done here on this important issue, and so thank you very much for your attention today. So I think we have 5 minutes for questions. Anyone? Back there, please. And someone will bring you, there you go.
Thank you. Lou Gagliano of the CTAC. A question about geography and places where value-based contracting and hospital reimbursement are tied to quality outcomes like patient infection rates and others. Can you comment on why certain states and areas where that's more prevalent in terms of incidence, meaning value-based contracts and pointing people and to go to those hospitals where better care is given as measured by some of the things that MACRA is measuring? Have you done any work to look at those geographies and reached any conclusions?
That's a great question. So I guess two comments. One, the first is, we have, here's a study, Paul is a co-author on this one, that looks for heart attack, acute care for a heart attack, looks at geographic variation, and probably not surprising, we do see wide variation. The dark green regions are high value regions. One of the things you'll see, though, is that some of the high value areas are actually low quality but low cost, and some of the low value areas are high quality but low, right? So there's not exactly a tight relationship necessarily, which I think is policy relevant. So that speaks, I think, at a high level to your question. You have, but not exactly your question. Your question, I think, is about what are how do contracting practices vary across the country, and what are some of the metrics that are tied to, and sort of, I don't have a great handle on that for the commercial side. I think I would look to some of my fellow speakers to maybe take that up when they have the opportunity, but I think it's a great question. Anyone else? Back here, please.
A little technical. To what extent were the severity adjustment factors you used actually picked up in the payment rates for Medicare, or were they something apart from that?
Right. So there were three broad classes of risk adjustment. One, I would say, is sort of the simple demographics, age, sex, race. Another is because we knew where people lived, and there's this interest in socioeconomic determinants of health, is we would link people to their zip code, census data on poverty and education and employment. Okay, and then the third group, and I think the most important group, is sort of diagnostic type stuff, which is not surprising. Standard comorbidity indices. Probably the key one is for each of these conditions, HRQ tasked clinical experts with developing a risk adjustment algorithm that could be used in administrative data by hospitals themselves or others to sort of assess their performance, right? You don't need the rich post-discharge data that we actually are fortunate to have. And so here's the risk adjustment model for, those are the parameters, we won't interpret them, for AMI heart attack. You can see what goes into them. So it's age, is there a transfer, and then these APR DRGs. So those are related to DRGs, but I think more fine-grained. It's a bit of a black box because this comes from 3M, and the underlying algorithm is not open source. They just give you the tool to run the data through. So I think there's what I'm inclined to say is that most of this is happening under the hood of DRG adjustment. Anyone else? Thank you very much.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.